There are some wounds that hospitals almost always treat wrong. Now, hospitals save lives every single day. They handle emergencies, they stabilize people, they get people through some of the scariest moments of their lives. But after being a doctor for a number of years, when it comes to wounds, there's a frustrating pattern. Mistakes keep happening, not because people don't care, but because wounds don't shout the way a heart attack or stroke does. They whisper. And when you miss those whispers, patients suffer. And whether you're a nurse, a caregiver, or a student, or someone who's been through a hospital stay yourself, you'll leave this video knowing exactly how to treat these wounds. I'll never forget during residency, walking into the room of a patient who had been admitted for pneumonia. He'd been in bed for weeks. When the nurse rolled him, there was a pressure ulcer on his sacrum that tunneled down to bone. And the thing is, it didn't happen overnight. That would have been forming quietly over days, maybe weeks. Nobody caught it when it was just redness. By the time I saw it, it was advanced, and the path forward was long and painful. I remember standing there feeling guilty. Like, how could this happen in a hospital? With staff, with protocols, with specialists right down the hall. And that brings us into the first type of wound. Number 7 is pressure injuries. These are the classic bed sores people have heard about. They happen when skin and tissue are squeezed between bone and a surface like a mattress or wheelchair for too long. The earliest warning sign is a red spot that doesn't blanch when you press it. That's stage 1. That's the body saying, help me. But in hospitals, that note might get charted and then forgotten. A week later, the patient has a stage 3 or 4 ulcer, painful, infected, sometimes even life-threatening. Here's how I explain it to families. Skin is like grass. If you step on it for a second, it springs back. But if you stand there for hours, the grass dies. Skin is the same way. And unless someone moves a patient, the skin can't recover. I saw this with a patient we'll call Miss R. She came in after a hip fracture. She was 86, frail, and couldn't move on her own. The surgical repair went great, but because she wasn't turned enough, she left the hospital with a deep sacral wound. She went in with a broken hip. She left with a broken hip and a pressure ulcer. That's the kind of thing that changes someone's life. Number 6 is moisture-associated skin damage. This one is sneaky. When skin stays wet from sweat, urine, stool, or wound drainage, it starts to break down. Hospitals often confuse it with pressure injuries, but the treatment is different. Moisture injuries need barrier and protection. Instead, too often they get treated like pressure ulcers and things get worse. Think about leaving a paper towel on a wet counter. At first it's fine, but if you walk away and come back hours later, that paper towel has turned into mush. Skin does the same thing. I remember one gentleman with uncontrolled diarrhea after antibiotics. His skin was so raw, so inflamed, that he couldn't even sit comfortably. What he needed was moisture barrier cream, frequent gentle cleaning, and protection. Instead, his chart labeled it stage 2 pressure injury. And because of that, he wasn't given the right care. That's how important it is to get the diagnosis right. Number 5 is surgical site complications. The incision might look fine at discharge, but if the drainage changes from clear to cloudy or the edges separate, those are red flags. Hospitals look for the big signs like high fever, bad labs, but the quiet changes, those get missed. I once saw a woman after a C-section. She went home doing well, but a week later she came back with redness spreading out from the incision. She didn't have a fever yet. She didn't look sick, but her wound had changed. And because someone actually listened to her concern and looked closely, we caught the infection early. If we hadn't, she would have ended up with sepsis. That's why I say wound care is more like detective work than firefighting. You don't just look for big flames, you look for smoke, for subtle clues that something isn't right. Number 4 are leg ulcers, venous, arterial, or mixed. These require nuance. Without vascular screening, hospitals are flying blind. Sometimes they put on no compression at all, letting swelling take over. Other times they throw on tight wraps without checking arteries. Either way, the wound loses. Here's an analogy I use with patients. Veins are like a highway going uphill. If there's no guardrail, cars slide back down. Compression is that guardrail, but if the road going into town, the arteries, is blocked, adding a guardrail won't help. You need to fix the road first. I had a patient, Mr. J, was swelling so bad his shoes didn't fit. He had a shallow ulcer on his shin. In the hospital, he was given antibiotics and sent home. No compression, no vascular check. By the time he got to wound clinic, the ulcer had doubled in size. All because compression wasn't started early. Number 3 are diabetic foot ulcers. Hospitals focus on infection. IV antibiotics, blood sugar control, and that's important, but they forget offloading. And without offloading, nothing heals. It's like trying to patch a flat tire while still driving on it. The patch won't hold. Until the pressure is off, the wound won't close. One of my patients had an ulcer under his first metatarsal, the ball of his foot. In the hospital, they gave him antibiotics and dressings, but he went right back to walking in his regular shoes. The wound kept reopening. When we finally got him into proper offloading shoes, things turned around. Number 2 are infected wounds, mislabeled as cellulitis. This one drives me crazy. A hot, swollen leg gets antibiotics. Redness improves. Everyone cheers. But nobody looks under the dressing. Maybe there's still dead tissue. Maybe there's an abscess. Without looking, the root cause stays. That's like turning down the volume on a smoke alarm without checking if there's still a fire in the kitchen. I've seen patients sent home on antibiotics who still had necrotic tissue hiding in the wound bed. They got temporary relief, but the infection came roaring back. The wound doesn't heal because the root problem never got addressed. And finally, number 1, palliative wounds. These wounds, tumor wounds, terminal skin breakdown, aren't about healing. They're about comfort. But hospitals sometimes treat them like regular wounds. Aggressive dressings, frequent changes, unnecessary pain. I once cared for a woman with advanced cancer. Her wound wasn't going to heal. What she needed was odor control, gentle dressings, and dignity. Instead, in the hospital, she endured painful daily dressing changes with products meant for healing. It broke my heart. Sometimes the goal isn't closure, it's comfort, and missing that is one of the greatest mistakes. So there you have it, 7 of the worst wounds hospitals often treat wrong. And here's what I want you to take away. The worst mistakes aren't usually about bad people. They're about systems that reward speed over subtlety. Wounds whisper. Hospitals are trained to listen for shouts. So if you're a nurse, advocate. Actually turn the patient. Actually check the skin. If you're a caregiver, speak up. Ask, can we look under that dressing? If you're a provider, remember that wounds change daily. The absence of fever doesn't mean the absence of infection, because the worst wounds aren't just bad luck, they're missed opportunities. And the earlier we catch them, the better the outcomes. Thanks for watching. If this helped, check out my next video on foot hygiene. It's one of those things we all assume people know how to do, but the little details matter more than we think. Stay informed and heal well.